Hello, everyone. Welcome to our live streaming session, where we bring you an inspiring and forward-thinking educational course. Today's topic is defining aspiration pneumonia, a critical discussion led by an expert in the field. I'm Diana Markai, and I'll be your host for this session, with our distinguished and highly experienced speaker, George Barnes. It's truly wonderful to have so many dedicated professionals joining us today. It is a pleasure to share this continuous education journey with such a passionate community. Your insights help us keep delivering high-quality courses, so I encourage you to complete the feedback form that will be sent to you afterward. Aspiration pneumonia has been a misunderstood topic in healthcare. This term is often overused, leading to unnecessary fear and confusion. But what exactly is aspiration pneumonia? And for what matter, what is pneumonia? This course will break down the definitions, clarify when a patient may have or be at risk of developing aspiration pneumonia, and guide you toward evidence-based decision-making. Leading us in this essential discussion is the renowned George Barnes. George is a board-certified specialist in swallowing and swallowing disorders, with expertise in dysphagia management, diagnostics, and clinical decision-making for medically complex patients. Beyond his clinical expertise, George is deeply passionate about making educational practical and ensuring that quality care is accessible to all. Before we dive in, I would like to introduce Ready, Set, Connect, the organization presenting this course.
Ready, Set, Connect is dedicated to educating people by inviting notable speakers, clinicians, and educators to share their expertise. We provide an online platform for therapists and educators, thereby facilitating meaningful consultations from the comfort of home. Our platform includes features like integrated notes, data tracking, calendars, and appointment reminders, making practice management efficient and user-friendly. And the best part? Ready, Set, Connect offers one of the most affordable practice management solutions, including a free plan. For more details, visit our website at www.readysetconnect.com.
Now, without further delay, let's welcome George Barnes to take us on this enlightening journey.
Hi, everyone. Thank you so much for joining me, and thank you to Ready, Set, Connect for hosting. Oops, my patient is aspirating. Defining aspiration pneumonia. Because to find the answer, we have to understand the problem first. And that's what we're going to be talking about today. To understand how to manage aspiration pneumonia and dysphagia in many cases, we have to know how to identify, define, and look out for the certain criteria that need to be met for an aspiration pneumonia diagnosis to be made, an accurate one to be made in the first place. So thank you again for joining me, and let's get right into it. Okay, our learning objectives. List the different types of pneumonia and its pathophysiology. So what we're going to find here is that there is actually a lot of different types of lots of different types of pneumonia diagnoses. And where does aspiration pneumonia fit there? Is it a separate diagnosis? Can you see it in other diagnoses? So yes and yes. So the water is kind of muddy, but we're going to try to clear all of that up for you guys. So identify the salient features of aspiration pneumonia. How do we know when a true aspiration pneumonia diagnosis can be made? And what kind of features should we be looking out for in order to make that diagnosis? And then to describe how we can best assess the aspiration pneumonia risk. What variables need to come into play? What should we be looking at? What should we be trying to manage? So a little bit about myself. My name is George Barnes. I am a board-certified swallowing specialist, and I spend most of my time in a critical illness recovery hospital. And so in this hospital, I see lots of patients with a very high level of medical complexity. Think tracheostomy tubes, mechanical ventilation. So a lot of those risk factors that we see in the research, sometimes patients have a few, maybe they don't have a ton. And our patients in the critical illness recovery hospital, another word for that is the LTAC environment, we tend to see a lot of those risk factors, a lot of those variables, which tell us that not only are our patients at risk of dysphagia and aspiration, but they are at risk of pulmonary infection. And so these are the types of patients that we want to pay closest attention to, which is why understanding how a diagnosis of aspiration pneumonia is made is so important, so that we can identify it when it happens and come up with an accurate and effective treatment plan and plan of care to make sure that it doesn't happen again, or to make sure that we manage it while it is happening. And so I also spend some time in a small community hospital. I run a mobile fees company that services mostly New Jersey and parts of Pennsylvania and New York. And I'm a writer, a mentor, a teacher as well. So why do I do all of these things? I have a passion for cooking and, of course, eating. Who doesn't? And I've gravitated toward a career dedicated to helping others enjoy these same simple yet profound and deeply meaningful pleasures in life. And could you imagine going any length of time without eating or drinking, even a day? I've my best friend in the world grew up together, and he was Jewish. So during Yom Kippur, I would, during those times, I would also fast when drink or eat anything from sundown to sundown. And it was difficult, right? My mouth was so dry, it's like a desert in there. And that was from a day. So could you imagine going that length of time for days, weeks, months without eating or drinking? It would be terrible to even think about, let alone to experience. Yet many of the patients that I see have already come into my hospital going sometimes that length of time without eating or drinking. And so that's why our job is so important. What we do is so meaningful to the lives of other people. We can give them that pleasure, even if it's a small amount of it, to give them the pleasure of eating again, of drinking again. That can mean the world to some patients. And when I'm not doing these things, I'm a pretty boring guy. I spend most of my time with my family, cooking, reading. Here are my disclosures, receiving royalties for this presentation. I am involved in a volunteer project, a research project aimed to objectively calculate aspiration pneumonia risk. You'll see some research, especially toward the end of this presentation, on gathering what is basically the outcome of that research thus far. Basically, a colleague of mine, Doreen Benson, and I sort of went through some preliminary research and came up with some variables, some factors that are important toward identifying the risk of aspiration pneumonia, so that we can sort of look at the whole picture, not just at dysphagia, not just at the risk of aspiration even, but at the whole picture. And we'll talk about that in a little bit more detail. Okay, let's get into it here. So we have pneumonia, and then we have aspiration pneumonia. Where do these two fall? How do we identify one versus the other? And how do we even diagnose pneumonia in the first place? Our role as speech pathologists is incredibly important toward putting the pieces of the puzzle together when we have a pneumonia diagnosis. So you may see in the chart, an order for a speech pathology evaluation, for a dysphagia evaluation. And sometimes it's very general, and other times it's specific. But some of those times it may be because the patient arrived in your hospital with pneumonia, or even specifically aspiration pneumonia. And that team, the interdisciplinary team, will want to know what are the chances that this is aspiration pneumonia? And so they call you in to say, is there dysphagia? Is there a likelihood of this patient to aspirate? And was there a likelihood that they did aspirate before? And so what we're seeing now is actually an aspiration pneumonia. And so can we manage the dysphagia to reduce the chances of, number one, making that condition worse, and number two, preventing it from happening again? Because that is what an accurate diagnosis is all about. So oftentimes, or all of the time, we can't prevent something from happening if it's already happened, but we can prevent what happened now from happening again in the future, which is why identifying a correct diagnosis using key criteria identified by the research is so important toward not only finding out what's going on and treating it, but also preventing it from happening again. And so as speech pathologists, as those professionals who specialize in dysphagia, we can play a huge part. We have a huge role to play in identifying that risk and managing that risk so that what's happening now doesn't happen again. Some pneumonia statistics. Pneumonia is the #1 cause of infection in hospital admissions, #1. Over 10 million people are diagnosed each year, and $10 billion, billion with a B, in healthcare costs per year. Think about it this way. If we were to maybe manage just some of this a little bit better than we are right now, say 10% better, we could save 1 million people. We could save healthcare $1 billion. What could we do with that amount of money? To bring that amount of improvement to a healthcare system can mean the world to the people that we're trying to serve. Okay, so what is the pathogenesis of pneumonia? So one thing we want to look at is if infectious material are entering the lungs, right? In the case of aspiration, it's dysphagia. We're looking at through instrumental studies to see if the patient has a likelihood of aspirating, and if they are at risk of aspirating, what's the likeliness of them aspirating different types of consistencies, and when does it happen in terms of timing, and can the patient close their airway and for how long, and if aspiration does occur, how does it happen and when does it happen and on what types of consistencies? So that's the entering the lungs situation. But it doesn't have to be food, liquid, secretions, vomit, reflux. It doesn't have to be any of those things. It could be breathed in from whatever type of bacteria, virus, or fungus may enter the lungs from the environment. And so that's one piece of the puzzle. Next is the ability to clear out or fight off an infection. So that's the lung's ability to protect itself. And, we often think of the lungs as these two sort of defenseless sacs, these little balloons that are just sitting there, when in reality, they're pretty strong. They have a really complex array of defense mechanisms to help protect them against that sort of scenario where something's entering the airway and we want to get it out. And so we'll talk about that in a bit. And then, so if something enters the lungs, can't clear it out, then an infection is going to ensue in the lungs. That's called pneumonia. Simply put, it's a pulmonary infection. Which begs the question, are lungs sterile? No, they're not. So actually, the lungs have, for a long time, we did think that they were sterile. But we've come to realize over time that the lungs actually, you think of the gut microbiota. So the lungs actually have their own microbiota, this sort of living organism of bacteria in the lungs. And that occurs from the regular inflow and outflow of bacteria because we aspirate. healthy people aspirate throughout the day, especially while we're sleeping. And that is what brings bacteria into the lungs. And, got to think about it this way. Our whole body is made up of bacteria, and much of that bacteria is helpful. It can help us fight off other types of bacteria. It can help us basically complete some vital functions. Without it, we wouldn't be able to survive. And so, no, the lungs are not sterile. They are made for bacteria to enter in and to often be cleared out before they can get to the point that they are replicating and spreading to the surrounding tissues and causing what we know now as an infection. So, no, it's not just having the bacteria, virus, or fungus enter into the lungs, because that happens constantly. What it is the lungs' inability to protect itself against that bug from spreading. And so the lungs are quite good at protecting themselves. We have mucus that lines the entirety of the respiratory system, starting in the mouth and nose and going all the way down to the terminal bronchioles. And what mucus is for is, what is mucus, right? It's sticky, right? Sticky secretions that stick onto materials, foreign materials, before they can make their way down into the depths of the lungs where an infection might occur and where an infection might have a significant impact on that patient host. So it catches onto it before it's too late, before it makes its way all the way down. And mucus also protects against certain infections by having parts of the immune system inside it, some abilities to fight off that infection. And then we have cilia, these tiny little hairs that will also line most of the respiratory system in order to push up through a process called mucociliary clearance, those foreign materials out into the environment where we can cough it out, clear it out. Which brings us to cough. Having an effective cough, an ability to clear our throats and remove certain mucus from our lower airways and upper airways in order to keep our lungs clean and protected. And then we have our immune system, which is filled with white blood cells such as macrophages that seek out and destroy what cannot be cleared out, what cannot be absorbed into the bloodstream, so that we can keep our lungs clear of infection. So a bit more on mucociliary transit. Remember, the cilia lines these airways, right? So there's tiny little hairs and they push out foreign materials that might gather in those areas. So think secretions, food, liquid, bacteria, dust, viruses, fungus, whatever enters into the airway can be brushed up through a sweeping motion called mucociliary transit or transport. I also call this the mucociliary escalator, because it escalates materials up and out. And so mucus is all over these cilia, sort of like the oil to their gears. To catch those materials and to brush them up and sweep them out. And then eventually we cough them out or even swallow them down into the acidic environment of the stomach so they can be processed out and removed outside of the body before they cause an infection. We also have the ability to absorb materials in through the lungs. We have aquaporins. Now, these transmembrane proteins have been with us since we were in the womb, which allowed us to breathe essentially underwater and absorb excess fluid into the bloodstream. And we still have these today, which is why we are able to aspirate bit by bit here and there and absorb some excess secretions and fluid and possibly an aspiration from a food or liquid into the bloodstream. Typically liquid food is, by definition going to be more solid, more viscous, and more difficult to move into the bloodstream. So it does depend much more on simply if the patient is aspirating. We want to know what they're aspirating. which is why an instrumental study is so important, because we can identify what they are at highest risk of in terms of aspiration. Is it liquids because of timeliness of airway closure, poor timeliness of airway closure, or posterior loss from the oral cavity, spilling into the piriform sinuses, going over the posterior commissure into the airway? Or is it from residue, from pharyngeal residue, from food that builds up and eventually thins out and makes its way into the airway as well? So the instrumental study can give us that information so that we know, is the patient just aspirating small amounts of liquid here and there? And if so, is the risk really substantial? Is it something that we need to address immediately with, say, draconian measures such as an NPO status, or from thickening liquids and all of the risks that come with those interventions? Or, is the risk relatively low, and we can mitigate it with maybe some compensatory strategies and some positioning and maybe some exercises and training? Or is the risk of aspirating some viscous material, such as solid food, is that really high because we can't effectively push the food and liquid into the esophagus? And does it build up in the throat to the point that we're at high risk of aspirating truly solid and acidic material that will wreak havoc on the lungs? Those are two very different scenarios, and oftentimes we're seeing things in between those two extremes. And then we have our macrophages, our ability to fight off an infection. These are an immune system byproduct that help gobble up materials from spreading if they cannot be cleared out of the lungs, say through mucociliary transit, or through coughing, or through absorption. Okay. A diagnosis of pneumonia has three main criteria that need to be met. Number one, we have respiratory changes: desaturation, dyspnea, difficulty breathing, increased work of breathing, supplemental oxygen needs are increased. For example, the patient had no oxygen and now is on 2 liters of nasal cannula. Or the patient's on 2 liters of nasal cannula and now is on 6. Or they were on a nasal cannula and now they're on a non-rebreather. So you get the point. The more respiratory support they need, that may be an indication that something's going on. So they have to have some sort of change in their respiratory status. Abnormal imaging, typically done through a chest x-ray, which we can see here is only about 69% accurate. So, 1 out of 3 cases or so may be missed through this diagnostic process. And that's, just kind of the nature of imaging. Some imaging is better than others. CT scans are going to be much more effective, but not always used because they are, they provide more radiation for the patient, which is not good, and they're more expensive. So we want to be mindful of what tool is used to make that diagnosis, and is there a chance that it's inaccurate or maybe misinterpreted? And then we have signs of infection, right? Pneumonia, we need to have some sign of infection. There's fever, leukocytosis. Typically, the best way to tell, because oftentimes fever and increased white blood cell count, that is leukocytosis, may not always be seen. But if we can get a sputum culture, we can see that, yes, in that sputum, we are having increased bacterial load or some virus that we're identifying. And the best way to do that is to bypass the oral cavity, because there's going to be oral pathogens naturally that sit in our mouth, especially if oral care has been neglected. And so how do we bypass the mouth? Well, through bronchoscopy or through a thoracentesis, where we get access to the fluid in the lungs and we test it without contaminating it by having the patient, say, spit into a cup and have the oral bacteria that just sits in the mouth naturally. And that's the best way, really, to diagnose an aspiration pneumonia. If we are able to do a bronchoscopy or a thoracentesis and we get that material and we say, hey, these oral pathogens are spreading. And how did those oral pathogens get there? And how were they how are we unable to fight off that infection? Probably because of whatever medical complexities the patient has and host factors that they have. Unfortunately, though, a bronchoscopy and thoracentesis are highly invasive. They come with their own risks, and so they're often not done when we're making a diagnosis of aspiration pneumonia, which is why the diagnosis can and often should be questioned. We should see, was this diagnosis of pneumonia or aspiration pneumonia? Were all of these criteria met? And if not, why not? And what types of diagnostic processes did we use? Because our ability is to make an accurate diagnosis is always going to be limited to a certain degree, and it should be questioned because we're never going to be 100% sure. And so discussing these limitations with the team could help us, identify an accurate diagnosis if it is the accurate diagnosis, but also explore other options if, say, the diagnosis could not be accurately made. Any kind of infection is going to need a microbe. And so not all microbes are created equal, right? You have different types of microbes, and within those categories, we have lots of different types. So viruses, bacteria, fungi, and what they do is they replicate. Over time, they'll replicate usually fairly quickly and spread to the surrounding tissue because microbes love a party. They love to bring all their friends, and they love to replicate to the point that they are spreading. And when they spread, that is what an infection is. It's a spread of a certain microbe. So as these microbes replicate and spread to the surrounding tissues, we're going to start to see symptoms. What are these symptoms? Most of them are actually not always due to the microbe themselves, but due to what's called an inflammatory immune response. So if the immune system is functioning effectively, we're sending all of our troops essentially to the site of infection. So if it's in the lungs, we're sending through the bloodstream white blood cells, proteins, fluids, red blood cells, if, say, a capillary is damaged. And what this does is it effectively fights off the infection. It gets rid of it, but it's also adding a whole bunch of extra stuff into the lungs. And the lungs work effectively when we have adequate airspace for gas exchange. But unfortunately, if that airspace is filled with what's called exudate, immune system byproduct, there's less space for gas exchange, which means we're going to have some respiratory problems. And so underlying respiratory disease processes are going to alter the ability, number one, to fight off the infection and potentially clear out some of these potentially harmful pathogens. So let's think about respiratory disease in general. You might have a specific condition in mind, think COPD. The patient has COPD, and maybe they have some tachypnea, so increased breathing rates or increased respiratory rate. They may also, because of congestion, maybe some blocking of the airways, may have some decreased ability to cough and clear out the lungs. Okay, so this patient already is going to be at an increased risk of aspiration because of an increased respiratory rate, right? The more times we inhale, the more likely we are to inhale during a swallow and bring in some of those contents into the lungs as we are swallowing. So higher the respiratory rate is, typically the higher risk there is of aspiration, especially as we get into the mid-30s and 40s. So we also have poor clearance, right? With underlying respiratory disease process, we may not be able to clear out that aspiration. This, of course, increases the risk of infection, which means that we may get a pneumonia. That pneumonia is not going to make that respiratory disease any better. It's only going to worsen our respiratory status, worsen the tachypnea and the respiratory rate, worsen the ability to cough and clear out the lungs, increasing the risk of aspiration further, inability to clear out the lungs further, possibly exacerbating the infection and furthering the respiratory disease process. So those are patients that we want to pay very close attention to, those that have baseline respiratory issues that need to be managed effectively in order to overall manage their dysphagia, risk for aspiration, and risk for recurring infection. Okay, so ways that we can diagnose pneumonia. So you may see community-acquired pneumonia or hospital-acquired pneumonia. And these are important things to identify and to differentiate. So with community-acquired pneumonia and hospital-acquired pneumonia, we're going to be looking at two usually differently appearing patients. So in the community, we may see a patient who's walking around, relatively independent, ambulatory, maybe their health is a bit better, less medically complex. Whereas hospital-acquired pneumonia, this is an overgeneralization, but we may often see those patients who are, because you're diagnosed in the hospital, typically a few days after admission, and these patients tend to be sicker than those coming into the community. They're patients with longer hospital stays. They're more likely to catch those kind of nasty bugs that you see in hospitals. And so these, may be completely different types of patients that we're seeing with these two different types of diagnoses. And so with the community-acquired pneumonia, the person probably acquired it in the community, so it's more common, not as deadly, and twice as likely to be viral versus bacterial. Whereas if the person acquired the infection in the hospital, first of all, that patient is going to be, in general, more medically complex, may be more likely to have dysphagia, may be more likely to catch a nasty bug that's resistant to common antibiotics. With this higher medical complexity comes inevitably reduced cardiopulmonary health and reduced immune system health. And that infection that's acquired in the hospital tends to be more likely to be bacterial versus more likely to be bacterial and aspiration related than its counterpart in the community, which tends to be more viral and have nothing to do with aspiration. But we'll talk about the specifics because aspiration pneumonia can be seen, it's sort of a spectrum, it can be seen across other diagnoses as well. Hospital bugs, why are they so nasty? So hospital bugs usually have a strong offense. They're highly virulent, they spread quite quickly, and a strong defense. They're drug resistant. So doctors try very hard to come up with new antibiotics to fight off some of these super bugs, as they call them. But these bugs are really resilient. They can swap genes very quickly so that they're evolving over time, in real time. We take all of these generations to evolve over time, whereas hospital bugs can do it in a matter of days. MRSA is an example of a hospital superbug, those bugs that we tend to see inside the hospital that can be particularly nasty and can cause some serious issues. Okay, ventilator-associated pneumonia. And that is a diagnosis of pneumonia that happens 48 hours after the vent is placed. And number one, it's affecting patients who are already on the vent. So these are patients that already have difficulty breathing. They already have underlying respiratory disease processes. They already have lungs that maybe are not 100% healthy, unless it was a traumatic incident that happened, say, from a car accident. And so we may have a biofilm that kind of first starts on the top of the endotracheal tube and kind of makes its way down into the lower airways. And we're affecting patients who really don't have a fighting chance. They're on sedatives. They're usually not 100% conscious. They have a balloon, a cuff that's filled with air to allow the air to be pumped into the lungs and not be released back out. So, that cuff is there to make sure that they're adequately getting airflow into the lungs, and it's being taken back out through that machine, but it's not going to allow for the effective mucociliary clearance mechanism that we talked about before. We can't cough, we can't clear out our lungs, and even if we could, those sedatives are going to impair those reflexes. And so, people on the ventilator are going to have a lot of risk factors, and they don't really have a fighting chance because of all these other variables. Aspiration pneumonitis. This is an inflammation typically without infection. It results from aspiration of typically acidic sterile contents. So think gastric contents, inhaling chemicals, or medicine that was aspirated. And what first happens is a restriction of the bronchioles and atelectasis, or a collapse of the airways into our alveoli, and edema, or swelling of those airways. Unfortunately, if we're doing a chest x-ray, for example, it can often be indistinguishable from an aspiration pneumonia. So how do we tell the difference? Well, we want to be mindful of certain GI conditions that may increase the risk of reflux or vomiting. We want to be mindful of an aspiration event that may have occurred with a certain medication. We want to be mindful of their recent history, where they work, if they could have accidentally inhaled a certain chemical. And also keep in mind that this does muddy the water a bit, but this aspiration pneumonitis, this what is not an infection, but an inflammation, could become an infection if, say, antacids were used that reduce the acidity in the stomach and end up with bacteria building in the stomach, which ends up into the lungs, say, during an aspiration of reflux or vomiting. And dysphagia and reflux often co-occur, meaning this could be an issue of aspiration antegrade, from the top down as well. And keep in mind that a bacterial pneumonia may occur in 25%, 1 out of 4 of these aspiration pneumonitis cases. So the water is a bit muddy here. The diagnosis is not always that simple, but it's important to keep in mind. Okay, quick case study here. We got Jesus, 47-year-old male. So he wakes up in the middle of the night. He's gasping for air. 2 days later, he starts having some dyspnea, some difficulty breathing. He's coughing. And there are concerns because they do some chest imaging and we have what looks like an aspiration pneumonia. But you find out that there's a history of an esophageal stricture. He's had this stricture for a while, wasn't effectively managed. He didn't go back to the doctor when he was supposed to. And now he has worsening globus sensation over the past couple of months, but hasn't had it checked out. And so this might lead us to believe that maybe there was a reflux or vomiting episode that occurred, and that is what's happening. It's an aspiration pneumonitis, not a true aspiration pneumonia. And if you see slide 53 ahead, you're going to see that there are lots of different questions that we can ask during cases like this to differentiate what happened, why it happened, and what type of pneumonia we might be looking at. Other ways to diagnose aspiration pneumonia are which side it's on, right-sided pneumonia or left-sided, the specific lobe that we're seeing, right lower lobe, for example, which we'll talk about. Interstitial pneumonia, which is pneumonia, an infection that occurs just outside the alveoli, or bronchopneumonia, which is throughout the lungs, including the bronchioles and the alveoli. Okay, right lower lobe. Is it significant? Yes and no. The right main stem bronchus is more vertically angled. So it kind of creates this slide where anything aspirated may make its way more easily into the right lower lobe. And anything that we're aspirating, food, liquid, vomit, secretions, is by definition going to be heavier than air. And so it's going to end up in the gravity-dependent area of the lungs. So typically, yes, right lower lobe is quite suspicious. However, based on the patient's position at the time of aspiration, any lobe may be affected, or all of them, given a sufficiently large volume. And so we want to be mindful of our patient's positioning when the aspiration event occurred, if we were able to identify it. And so Hector, 76-year-old male, had experienced a right CVA. He appears to be coughing at bedside with PO intake, but the chest x-ray reads left lower lobe. And so the left lower lobe infiltrate. And so the medical team, they were expecting right side. So they say, no, this isn't aspiration pneumonia. We don't have to worry about it in terms of dysphagia or aspiration. Let's move on to some other possible causes. But you know that the patient had a right hemisphere CVA and tends to be left leaning, making it more likely that the gravity-dependent area of the lung to be on the left side during a potential aspiration event. And so looking further and investigating further to see, is there dysphagia? Is there a likelihood of aspiration may be warranted? Okay, what are the stages of pneumonia? First stage we have is congestion. Day 1 and day 2, we typically see the alveoli and the blood vessels beginning to fill up with fluid. And then stage 2, red hepatization phase. This is day 3 and day 4 when the exudate starts to fill in the airspace, right? That immune system byproduct, the red blood cells, white blood cells, proteins, everything's going toward the infection to help fight it off. And the lungs take on this red appearance because of the red blood cells. And then we have the gray hepatization phase. This is when the red blood cells start to break down around day 5 or 7. And finally, resolution. And we want to be mindful here. So as the exudate is being processed by the enzymes and macrophages, we're absorbing those materials, coughing out the secretions. This range is huge. It can be day 8, or it can be all the way up to 3 weeks where the patient is still experiencing signs of symptoms from this infection. Lots of coughing, difficulty breathing. And so you might want to be mindful. Say a patient arrives in subacute and they're concerned because this patient's coughing during the meal. But if you look at the chart, you'll see, they were admitted to the hospital on day 1 and they were discharged on day 10. But that could give at least 2 more weeks of symptoms from this maybe community-acquired pneumonia that may have nothing to do with aspiration. And maybe they're just experiencing difficulty during meal times because they still have all this congestion they're trying to get up. What symptoms should we expect to see with pneumonia? So we may see some difficulty in their respiratory status, dyspnea, difficulty breathing, increased work of breathing, increased respiratory rate, tachypnea. We may see chest pain due to the inflammation. We may see a productive cough of sputum or even blood if a blood vessel has been broken, and an abnormal chest x-ray or breath sounds. And how do we treat it? Well, antibiotics, depending on the type, cough suppressants, but not too much, right? Only enough to decrease the cough. We don't want to eliminate it completely. A cough is a good thing, right? But seeing a cough sometimes scares us because automatically we're thinking aspiration and this patient's at risk of something going down into their lungs. But a cough, an effective, strong cough, means that even if something may occasionally go down that way, they have a strong defense. They're able to clear that out. And so we don't want to reduce that so much. Yes, maybe while they're sleeping to help them rest, but certainly not enough that it decreases that very vital function. And so they also may have pain medication and some respiratory support if, say, the respiratory status is starting to decline. Okay, now on to aspiration pneumonia. Aspiration pneumonia has up to 70% mortality and is 3 times more deadly than other types of pneumonia. 60,000 people die each year, which is an extraordinary number. What happens is we're carrying microbes with saliva, food, or liquid or vomit into the lungs, and that by definition is an aspiration event. And if those microbes spread, it could turn into an aspiration pneumonia. But it's important to be mindful here. It's not all about the aspiration, right? Because healthy people aspirate. We aspirate throughout the day in small amounts. We aspirate in our sleep. But rarely is that number of people going to be walking around with pneumonia because we have those defense systems lined up so that we can protect our lungs against the aspiration. So it's not that simple. Aspiration doesn't automatically equal pneumonia. So I'm going to stop and tell you a quick story. When I was a clinical fellow, I was doing PO trials with a patient, trying to liberalize their diet, get them away from thickened liquids and toward thin liquids, which was the goal of the patient. And the patient, I gave them a sip of water, and the patient started coughing violently. It was extended coughing, lasted a few minutes. I found out later that the patient was admitted to the hospital and diagnosed with none other than aspiration pneumonia. I was devastated. I couldn't believe it. I felt awful. And this affected me for a very long time. I've learned things since then, of course, and I'll always, make sure that I do an instrumental study before we start PO trials, understand the anatomy and physiology before we move forward. But what it did was it scared me. It scared me to do PO trials at all, to liberalize diets at all. And for a long time, I was extremely conservative because anytime that I heard a cough, I thought, oh my goodness, this person's going to get aspiration pneumonia. And so all of this is to say that we have to look at the big picture. It's not just about the aspiration. Lots of people are going to aspirate. Healthy people are going to aspirate and cough. Very often things go down the wrong pipe. Things happen. We need to look more past the is there a risk of aspiration and more toward is there a risk of developing an infection from that aspiration. And so I've learned since then to not always see cough as a bad thing, as long as we're looking comprehensively at the patient and trying to lower the risk as much as we can without trying to bring the risk to zero, because that would be impossible and often leads to increasing risk in other areas, such as dehydration and malnutrition and all the implications that that has on the patient's health. We want to look at lowering the overall risk of pulmonary infection and setting the patient up for the best chance of success. Does aspiration cause aspiration pneumonia? So Dr. Langmore in 1998 had a study, which at this point is probably older than some of you, where she told us that confirmed aspiration on an instrumental study is not a significant risk factor for aspiration pneumonia by itself. Now, I want to repeat that. Confirmed aspiration on an instrumental study is not a significant risk factor for aspiration pneumonia by itself. I myself need to be reminded of this every day because it's counterintuitive to what we think as speech pathologists. When you're a hammer, everything's a nail. And when you're a speech pathologist, everything tends to be dysphagia focused, aspiration focused. And we forget that there's a bigger picture that we want to look at here. So yes, everyone aspirates. Microaspiration may occasionally occur in healthy individuals, even silently, and is common during sleep. What's more important is how much is being aspirated, what's being aspirated, and who is doing the aspirating. What are the host factors? What are the variables specific to that individual that might increase the likeliness of an aspiration pneumonia from occurring? And so, yes, as a speech pathologist, we are charged with helping the team make that differential diagnosis. And it starts with understanding the dysphagia, understanding the diagnosis, the diagnostic process, and understanding what's happening in terms of their anatomy, their physiology, and their likeliness of aspirating and developing an infection. Because if a diagnosis is incorrect, remember, we're missing the cause of that condition. And if we miss the cause, we miss an opportunity to protect the patient from acquiring that condition again, which it can be devastating. All right, so an aspiration pneumonia diagnosis. We have to have all of those same criteria that are going to be involved with a general diagnosis of pneumonia. To remind you, we have respiratory changes, we have abnormal imaging, and we have signs of infection. On top of that, we're going to want to have maybe a sputum sample from a bronchoscopy, for example, that shows the bacteria originated in the oral cavity. That's kind of the very key criteria that makes us very suspicious of an aspiration pneumonia, right? Because if the bacteria started in the mouth, ended up in the lungs and started to spread, that tends to be related to aspiration, right? And those are the bacteria that might be suspicious for that sort of pathophysiology. Pneumococcus, Haemophilus influenza, Staphylococcus aureus, anaerobes. And then we have abnormal imaging. Now, generally in the gravity-dependent area of the lung, remember, think about positioning here, and it's typically not symmetrical. When we see symmetrical involvement, we tend to think more fluid buildup, more generally in the body. And the presence of dysphagia. Of course, you might think there's got to be presence of dysphagia in an aspiration pneumonia, but That may seem obvious, but may not always be the case in, say, non-dysphagia related aspiration pneumonia. And so Coyle and Matthews in 2010 came up with an article called A Dilemma in Dysphagia Management. Is aspiration pneumonia the chicken or the egg? It's a fantastic article, and I highly recommend you read it. But in short, what we're doing is we're differentiating two seemingly similar type of cases. One is the chicken, what we often think of when we think of a patient who comes down with aspiration pneumonia. Patient aspirates, pneumonia occurs from, say, an acute, subacute, or chronic dysphagia. But then we have the egg, something that happens maybe just as much, but we don't think about it as much. The patient gets pneumonia that comes into the facility and then aspirates, say from deconditioning, reduced functional reserve. Now, this may typically be from an acute condition, such as a pneumonia, that is reversible, meaning when that patient recovers, they will no longer theoretically have dysphagia. And so in the meantime, though, that patient may be weak, they may be lethargic, they may be delirious, they may be bedbound, they may have all of those host factors that make it more likely to make that pneumonia worse through aspiration. But distinguishing the two is very important because we're going to want to manage the dysphagia a bit differently. We're going to want to try to hold the patient off as much as possible until they've recovered, until their function starts to come back. Whereas the chicken, on the other hand, we're going to want to be mindful that this may be a recurring type of situation. We may be a little bit conservative as the patient starts to recover from that pneumonia because we don't want it to happen again. And so in that article and in some of his other work, Dr. Coyle kind of differentiates between dysphagia-related and non-dysphagia-related aspiration pneumonia. So in dysphagia-related aspiration pneumonia, we are seeing dysphagia. We're seeing infection, and we're seeing it typically from oral bacteria, what we normally think of in terms of aspiration pneumonia. Whereas non-dysphagia-related aspiration pneumonia may be from an aspiration pneumonitis that turns into an infection or looks like an infection, or a ventilator-associated pneumonia that may look and appear and really be very close to an aspiration pneumonia, but affected the patient when they didn't have a fighting chance. And temporarily altered mentation, say from an acute condition, that of course appears like the patient has dysphagia, at least in the short term, because they're lethargic and weak and bedbound, but is bound to recover. And so for those patients, you don't want to manage the patient conservatively for a long period of time, because you want to be able to be mindful that that patient eventually will recover and will need to advance and ease up on conservative recommendations, so eventually we can change those as they recover. A few case studies to demonstrate some of these points. We have Amani, 34-year-old female, status post ETOH withdrawal. She has temporary nausea and vomiting and altered mentation with bacteremia, sepsis, and seizures. And now we're seeing a right lower lobe opacity on chest x-ray. Is this dysphagia-related aspiration pneumonia? So, we want to be mindful that this patient has a temporary condition, and this altered mentation, yes, may lead to dysphagia and aspiration. And we want to be mindful that this was from a nausea and vomiting event that may be more likely to be an aspiration pneumonitis. How about Francisco? 79-year-old male on the vent comes in with, quote, aspiration pneumonia. Now you're concerned, right? You're feeling terrified that you don't want to start with PO trials with this patient who was intubated and maybe at risk of getting another aspiration pneumonia. But for a patient like this, we want to at least consider that this patient may be closer to a functional status now, if they've since been extubated. Of course, we're going to want to look comprehensively at the patient. We're going to want to do an instrumental study. We're going to want to look at all their risk factors, but we don't want to be petrified to move forward with the patient just because they have this diagnosis, because that diagnosis of aspiration pneumonia could have been made while the patient was on the vent and didn't have a chance to clear out their lungs because they were on sedatives with an inflated cuff, for example. And Gertrude, 82-year-old female admitted with pneumonia. The patient remains confused and variably responsive and begins to cough on all PO trials. So the example of the egg versus the chicken. The patient that comes in with this seemingly acute reversible condition and is having short-term dysphagia that hopefully will resolve as the condition resolves. Okay, so who gets aspiration pneumonia? The likeliness is going to increase with gross aspiration, often silent, in, say, patients with drug overdose, impaired consciousness, neurological disease, head and neck cancer, GI abnormalities, and respiratory compromise. Elderly patients are at a particularly high risk, given up to 1/3 incidence of dysphagia at baseline in geriatric patients, and a higher susceptibility to medical complexity, severe illness, and infection in this population. We want to remember that aspiration pneumonia is a continuum. It can overlap with other pneumonias. It may be a part or the sole cause of the infection. And oropharyngeal dysphagia may increase the odds of any type of pneumonia by 12 times in the elderly, and oropharyngeal dysphagia is found in up to 70% of elderly patients with pneumonia. Okay, so where can we see aspiration pneumonia? Where can we find aspiration pneumonia? In community-acquired pneumonia, between 5 and 15% might be related to aspiration. In hospital-acquired pneumonia, up to 50%. It's a huge range because of the diverse types of patients we see, but up to 50%, which is huge. In nursing home acquired pneumonia, we may expect 18% of that diagnosis to be related to aspiration. And in ventilator-associated pneumonia, over 90%. And this is because that pathogenesis of that disease process is very similar to aspiration pneumonia, if not identical, right? An oral pathogen enters the lungs, which cannot be cleared out, so mostly because of what we talked about, those sedatives and an inflated cuff. And we may find that aspiration pneumonia increases depending on the setting that we're in. Outpatient, inpatient, and nursing home is going to increase the likeliness because of those patients that we tend to see in those settings. So outpatient, hospital, and nursing home, you see the rates starting to rise there. How about silent aspiration? Now, most episodes of aspiration pneumonia are silent or unwitnessed. There's a high incidence of silent aspiration in patients with community-acquired pneumonia, and older and or deconditioned patients are more likely to aspirate at night and are more likely to have unwitnessed aspiration, say if they are eating by themselves, or silent aspiration because of reduced sensation. And so this muddies the water a little bit further because it can be difficult to pinpoint that aspiration to one event that occurred. NPO status. Should we be managing our patients with NPO recommendations? We certainly, on one hand, don't want our patients aspirating gross amounts, say if their condition is acute and temporary and they're eventually going to recover. And NPO may be warranted in these cases, but we have to remember that NPO status will not prevent aspiration. We can't take secretions away from a patient. We can't take saliva away from the patient. Tube feeding will not prevent aspiration. In fact, it often increases the risk of aspiration pneumonia. And we have to remember that life-saving medications may be needed. So we need to consider all of these things with the interdisciplinary team when we are considering an NPO status. NPO except for meds. Should we be making this recommendation? Now, on one hand, aspirating meds can be devastating to a patient. The airways don't have the same protective layer of mucus and bicarbonate that the stomach has, and so those medications can wreak havoc on the lungs. But we want to ask ourselves what meds are needed. For those severely dysphagic patients, we want to say, can the patient go a day or two without meds? Some can and some can't. Is there another access point other than the mouth? For example, a nasogastric tube, a PEG tube, or an IV line? And we want to discuss ultimately the risks and benefits of moving forward with that recommendation with the team before we make any kind of recommendation. Derek, 89-year-old male with dementia. He's got a complex medical history with late-stage dementia. He's bedbound with very poor oral intake. He enjoys ice cream and pudding, but has confirmed aspiration on all consistencies. Now, when we're considering a case like this, we want to remember something. In patients with advanced dementia, feeding tubes do not extend life, prevent aspiration pneumonia, prevent malnutrition, improve pressure injuries, provide comfort, or improve overall function. So they don't do a lot of the things that we've placed the PEG tube to do. Instead, they may increase issues with the feeding tube complications, discomfort, and restraints. When do symptoms occur with aspiration pneumonia? We're typically seeing clinical features within a few hours or a few days after the aspiration event, so fairly quickly. And this may be helpful if, say, we're advancing someone's diet and we want to watch the patient closely, if we're trying to look out for all of those criteria that need to be met for a pneumonia and an aspiration pneumonia. And oftentimes, there is no aspiration event, say in the case of silent aspiration or unwitnessed aspiration, and further investigation needs to be warranted. These are the questions asked, the questions to ask to kind of differentiate different types of pneumonias and see if dysphagia is important, and if it is, whether or not we need to investigate further. And so these sort of help us when we're on the fence and not really understanding what type of pneumonia this is. How should we manage it? These questions should help us bring some of that key information to light. Okay, and we're going to conclude with some risk factors to be mindful of with the risk of aspiration pneumonia. Number one, we want to keep a lookout for the risk of aspirating, how much the patient is at risk of aspirating, how frequently, and what type of materials they're at risk of aspirating. And that's the microbiologic contents of the aspirate. Is there a high risk of aspirating something laced with bacteria from the mouth because of poor oral care? Are they more likely to aspirate food versus liquid? And their ability to fight off and protect the lungs if that aspiration is likely to occur. And so here are our different variables that we're going to want to consider. The volume and frequency of aspiration. Of course, some of these from an antegrade standpoint, a top-down aspiration are going to be familiar to you, but then there's also retrograde. What's the chances of reflux? And vomiting and refluxing harmful bacteria that may be increased due to reflux medication. Bacteriologic contents of the aspiration, want to be suspicious of things that are related to oral health, and then retrograde as well, which we talked about. And the ability to clear out the lungs. Think certain medical conditions as noted here, reduced overall function, functional mobility, increased dependence, and pulmonary health. And the ability to fight off an infection that can't be cleared out. Want to look at things like their nutritional status, their medical complexity, their comorbidities, and the presence of other infections. We only have a certain finite number of resources in the body. And if we're fighting off an infection somewhere else, it may be like fighting a war on two fronts. We may not have the same number of resources that we need to fight off an aspiration pneumonia. And so when we're thinking about overall risk, we want to steer clear of looking at just one risk factor, like the penetration aspiration scale, for example. Instead, we need a comprehensive approach, examining and managing multiple risk factors together. And this is the process that I use. I look at all of the variables that fall under each of these risk factors, all of which really need to be met for a risk of aspiration pneumonia to be increased. So we have the risk of aspiration, the risk of being unable to clear out that aspiration, and the risk of being unable to fight off an infection that may occur from aspiration that cannot be cleared out. And you'll see all of the most important variables that are involved in each of these categories that, again, we've developed together, I've developed with Doreen Benson through our preliminary research. And crossing out two of these variables to see what we can manage here. And we really can manage most of these variables, if not directly as a speech pathologist, then indirectly through our recommendations and referrals to the interdisciplinary team. There's a lot that we can do outside of strictly managing aspiration and treating dysphagia. And so thank you to Doreen Benson for doing a lot of the sort of spearheading of this research and helping us take the research that already exists and kind of organize it in this way. Okay, quick recap. Aspiration does not equal pneumonia. Aspiration pneumonia is more likely to impact older, more fragile patients, and understanding the diagnosis is the first step towards finding the right solution. Thank you so much for listening.